Well, good evening. Good evening, ladies and gentlemen, and welcome to this Wolper Wellbeing webinar, hosted, of course, by Wolper Jewish Hospital and Friends of Wolper. And our topic tonight is the new New South Wales Voluntary Assisted Dying laws, also referred to as VAD. And we're going to talk about the facts. My name's Julie McCrossin, and it is my great pleasure to be your host this evening. I'd like to begin by acknowledging that we're broadcasting to you on the land of the Gadigal people in the Sydney area and pay our respects to elders past, present and emerging. Now, the definition of voluntary assisted dying, or VAD, in the New South Wales Health Easy Read Guide is this: voluntary assisted dying is when a person asks a doctor for help to end their life. And our purpose this evening in this webinar is not to debate the pros and cons of this new law in New South Wales. Our purpose is to give you accurate information about the VAD law and to answer your questions. And we'll also give you information about the palliative care service at Wolper Jewish Hospital. Now, quick housekeeping before we begin, and as more people join us, your questions are welcome throughout the evening. You can just put them in the Q&A. If you look down there on your screen, you'll see Q&A. Please put them in the Q&A. And thank you to those of you who sent questions in advance. Remember, we can't see or hear you this evening. The only way we can get your questions is if you type them into the Q&A. And as always, our question moderator is General Practitioner Dr. Lena Safro, and she'll be coming regularly onto the screen to bring questions that you've brought us, questions that you've sent in advance, and of course, live questions for the panel that you bring this evening. We'll answer as many of your questions as possible, but we can't give individual advice. And this webinar is being recorded and will be available on the Wolper Jewish Hospital website in a few days. Well, as I said, welcome. Just before we begin, I'd like to invite Dr. Lena Safro to make some opening remarks. Welcome to you, Lena. Your microphone's not on. Are you able to turn it on for her, Nat? Our technical, there we go. Welcome, Lena.
Thank you, Julie. Tonight, we remember and honor the incredible bravery and sacrifice of the Israeli soldiers and police officers and of all the innocent victims of terror. Our hearts ache for families who have experienced loss. We pray for the safe return of the hostages and the end of all loss of innocent life, and we hope for peace.
Thank you very much. Thank you. Amen. Well, welcome again, and especially to those who've joined us in the last few moments. If this is your first time with us, Wolper Jewish Hospital is a specialist medical, rehabilitation and palliative care hospital in the eastern suburbs of Sydney. And Wolper welcomes people from all cultural and religious backgrounds as patients and as clients, while offering care within a framework of Jewish culture, values, religious and dietary requirements. And our topic tonight, as I said, is the new New South Wales Voluntary Assisted Dying laws, VAD, the facts. That's the title of our session. Before I introduce our panel, we're going to do an audience poll, and it's really a way of our panel getting a chance to know a little bit about you. There's 6 questions. I'll read each question. You then answer the question. I'll give you a few moments, and then we'll see the group results on screen. And you're completely anonymous as individuals. So I'll ask Nat, our technical whiz, to put the first poll question up on the screen. Gender. Your gender, a single choice: male, female, other, prefer not to say. Thank you. And we can have a look, Nat. 18% of our audience so far is male and 82% is female. Thank you. Our second question goes to your age. Is your age under 40, between 40 and 60, between 61 and 74, 75 or older? Please tick a box. So only one person under 40, 13% 40 to 60, 31% 61 to 74, and 56%, so over half of our audience is 75 years or older. Thank you. And now the question of whether you've made an advanced care directive. Have you prepared a written advanced care directive? Yes or no? Thanks, Nat. 52% yes, 48% no. I won't go into the details of an advanced care directive. If you Google Advanced Care Directive New South Wales, you'll see that there's a form, but it's essentially spelling out your preferences for your medical treatment, including towards the end of life. Our next question goes directly to VAD, voluntary assisted dying. Would you consider voluntary assisted dying for yourself? Yes or no? Thanks, Nat. 87% yes and 13% no. Thank you. The next question relates to friends and family. Are you aware of anyone close to you considering VAD, voluntary assisted dying? Yes or no? Thank you, Nat. 26%, so 24 members of the current audience say yes, 74% no. And our final question goes to the question of faith. Do your religious views prevent you from considering VAD? Yes or no? Thank you, Nat. 10% yes, 90% no. Well, look, thank you so much, ladies and gentlemen, for sharing your thoughts with us tonight. That's just most helpful. So let's now welcome our two panel members for this evening. Our topic, the new New South Wales Voluntary Assisted Dying Laws, VAD, the facts. We're going to provide you with factual information about the law in New South Wales, not debate the pros and cons. We'll provide you with information about the palliative care service at Wolper and other parts of New South Wales, and of course answer your questions. Could I welcome to the screen Associate Professor Patrick Bolton and also Professor Richard Chye. And if I could introduce Professor Bolton first. Associate Professor Richard Bolton, do you want to wave so we can know who you are? Welcome, sir. Is a medical lead, the medical lead for voluntary assisted dying in the Southeast Sydney Local Health District. He's based at Prince of Wales. He works at a range of hospitals and in community settings. He's a complex care physician and he is the former Director of Clinical and Medical Services at Prince of Wales. So welcome to you, Patrick Bolton, and also welcome to Professor Richard Chye, who's a palliative care physician for over 28 years, I think, possibly longer, but certainly 28 years. He's Director of the Sacred Heart Supportive and Palliative Care Service at St Vincent's Hospital and a palliative care physician at Wolper Hospital as well. And we have a special audience member who will join us this evening to answer your questions, and I'll involve him in certain parts of the conversation, Rabbi Gad Krebs. And Gad is the college rabbi at Moriah College in Sydney. And I should say that Wolper Jewish Hospital, the Sacred Heart Hospice in the St Vincent's community, and also Calvary Healthcare Cogra do not themselves provide voluntary assisted dying. And we'll discuss that this evening and the thoughts behind that. And we'll also hear what steps are taken if a patient asks for information or access to voluntary assisted dying in those settings. Richard Chye will talk to us about that. But what I want to do first up, if I may, is come to Associate Professor Richard Bolton, because many of the questions that have come to us so far...
Sorry, Julie, Patrick Bolton.
Oh, I beg your pardon, Patrick. Can you give me a second? I'm just going to write that correctly on my sheet of paper. And my apologies, sir. Patrick, I want to get through some core information, because people really are here to hear about this new law. When did it become law in New South Wales?
So the New South Wales VAD Act came into force nearly 12 months ago, on the 28th of November last year. And
you're a physician who actually works with VAD. You've had patients whom you've helped to die.
Yeah, that's right. The Southeast Sydney service has had about 180 people ask. I can't recall how many people I've dealt with, but it must be 40 or 50. Bear in mind, I'm the person who has the largest full-time equivalent in our service. And I think I've supported about slightly over a dozen people in their lives.
Thank you. And I just want to say, before we get into the detail of the process or the core elements of the process, that if you Google voluntary assisted dying New South Wales, or if you Google VAD, V-A-D, New South Wales, you can get access to all the information we're going to refer to tonight. It's hard to take it all in. It's a serious, grave matter. And I want you to be able to look at accurate reading information. I would recommend Googling voluntary assisted dying New South Wales easy read summary, because that is the simplest version, but it is also available in many different languages. And there's really an enormous amount of information, Patrick, isn't there, available online. And also there's a statewide phone number, and I will repeat it later, but if it is a number you actually want to get, go and get a pen and paper, and that links you to the New South Wales VAD Care Navigator service. Can you explain what that service is and the purpose it serves in terms of information provision and any other purpose? Thank you.
Yes, so it's the statewide front door for VAD services. There are other ways of accessing VAD services, but it's intended to be an equitable, uniform access point across the state, bearing in mind that different parts of the state, and indeed the city, are differentially resourced with VAD services. So what it does is it seeks to ensure that everybody requesting VAD has equal access to those services, irrespective of where they live.
And online, I heard it's not only providing information, but they can help you find a VAD practitioner and help you access resources. If you could just explain, medical practitioners involved in this service do have particular training, is that correct?
That's right. There's a minimum training of a day and a half or so, which mostly covers the formalities of the VAD service. In order to become a VAD practitioner, one has to be either a recognised specialist, including a fully qualified GP, or have 10 years experience as a doctor. And I labour that point because, in fact, the bigger part of the work of VAD is not the technical bit, it's the relational bit. And so it's important, I think, that practitioners have an understanding of how the world works and can support people through a difficult journey.
Just say a little bit more before we go to the eligibility and so on, about what you mean about the relational bit.
So there's a technical VAD process, and I imagine we're going to cover some of that later in the evening, so I won't go into that in detail. I'm someone who's easily bored, and I was anxious that when I got into this role, I might find that after I'd done it a few times, I went, yeah, I can do that, so what? so far I'm not bored. And the reason is because two related reasons. One is that providing VAD services, and I think providing, to be fair, providing end-of-life services is a deeply personal thing. I'm not saying that there's not deeply personal encounters in other parts of healthcare, but it's strong. It's clearly very strong here, whereas it's not necessarily so strong in other healthcare encounters. The other bit is it's tricky. There's views of different people. There's a whole lot of stuff that interacts about, and again, we'll come on to this, about making prognosis, establishing the prognosis, establishing capacity. And so, although in the act or on paper, these questions look fairly cut and dried, they often aren't, and they need to be grappled with. And that's, for me as a practitioner, that's fulfilling and stimulating.
Thank you. And I am going to go through the key elements so that we can expose the audience to the whole a range of key issues, and then they can, through the Q&A, ask more questions if they wish. So just a reminder to you, please pop any questions in the Q&A. So first of all, the key age issue. Well, how old do you have to be eligible? You
have to be an adult, so 18 or over. In fact, the youngest person I think we've offered VAD to is someone in his early 40s in my service.
In your service. And the citizenship or residency criteria? So
you have to be an Australian citizen or resident, and you have to be a resident in New South Wales for the last 12 months. There is a, for that last criterion, New South Wales residency criterion, it is possible for you to be in New South Wales for a lesser period if you can establish a close and continuing relationship with New South Wales. And that judgment will be made by the VAD board. Okay, and we'll come to that VAD board in a moment. In terms of illness, I'll just read some words I've got online and then you could speak to it. That the person has to have at least one disease, illness, or medical condition that is advanced and progressive, and on the balance of possibilities, it will cause death within 6 months or 12 months for neurodegenerative disease. So tell us a bit more about the sort of diseases you're dealing with, illnesses and medical conditions, and how you assess advanced and progressive and so on. Sure. So I guess there's two dimensions in which to respond to that. One is to say about 2/3 of the cases of people who approach us have a solid tissue cancer, and another 10% or so have a hematological cancer. And as a general proposition, prognostication with that group is fairly easy because there's well worked out actuarial kind of data around that. I would note in passing, because it's particularly relevant to those groups, that that's your prognosis in the context of the treatment you choose or don't choose. So we had a woman ask for VAD who had metastatic breast cancer, and I'm advised that the nature of the breast cancer was such that had she chosen treatment, her life expectancy would be in the order of 3 years. She chose not to have treatment, and that put her prognosis less than 6 months, and so she was eligible. So the Act doesn't go, oh, you've got to go as hard as you possibly can in this. It's about the person and their circumstances. The other 25% is a mix of stuff. I think respiratory illness is probably the next biggest category, a bit of cardiac disease, and then some sort of renal disease, some what medical practices call rheumatological disorders like scleroderma, some little sort of tail end things. So that's one way of answering. The other thing is that people come to a sort of varying points in their disease journey. Some people come really quite late. And as you've indicated, I'm a generalist, so I'm not necessarily good at the subtleties of prognosis. But some people, it's obvious. This person has, a few months to live, and I don't need to speak to the oncologist. Some people, occasionally people look very well. And I need to go to the oncologist and say, tell me the prognosis here. There's a group of people who are not eligible under the Act, but many might think that they should be. I'm thinking about that. There's a Parkinson's disease is a disease that's very debilitating and many people hate it. But typically that debility kicks in well before they reach that 12 month because it's a neurodegenerative condition. So those people are eligible. Respiratory disease is very hard to prognosticate for. People who've got chronic emphysema get very sick when they're sick, but when they get better again, they're back up to how they were before. And it's very difficult to say how long they'll live. So there's those three kind of groups of people that we see.
Could I just say, you referred earlier to actuaries, and if I could just explain my understanding, actuaries are very sophisticated mathematicians, and for certain cancers and possibly other illnesses, but I'll speak for cancer, that there's good evidence for certain sorts of cancer on the likely survival rate, the likely time that you will survive. Yep. So there the clinician has guidance. Could I just say this, Patrick, because I want to move on so people can ask questions, but it sounds like the medical clinician involved in voluntary assisted dying services, there's still, as always, a great deal of clinical judgment.
There is. So the Act, there's a legal concept of discretion. You know, the decision one judge makes might not be the decision another judge makes, but they're both okay so long as they're broadly reasonable. And the same thing applies here. Each of us, there are circumstances where each of us are making a decision at those margins. And as I say, in general, if there's a relevant specialist in the area, I will defer that decision to that specialist. And I include in my use of the word specialist GPs. If somebody's got a GP who knows the person well and has been traveling on their lifelong journey with them, that GP may be much better placed than I am to make a holistic judgment about a person's prognosis.
Okay, thank you. And look, if you've just joined us, I'm talking to Associate Professor Patrick Bolton, who is the medical lead for voluntary assisted dying in Southeast Sydney local health district. And we're running through some of the key information about this law in New South Wales. People are very keen to know about capacity issues, but just before I come to that, another eligibility criteria is that there has to be suffering that the person considers, and I'm quoting now from New South Wales Health Information, the person considers it cannot be relieved in a way they consider tolerable. So it's intolerable suffering, but the patient's view on that is it has great weight. Is that what I hear in that?
Yeah, yes, that's right. So I'm oversimplifying, and I can come back and speak about this in more detail, but it would take time. If somebody says to me, I've got intolerable suffering, and whatever their form of words for that is, I'm inclined to accept that, unless it's wildly implausible. This is about their state of mind, and they likely met the prognostic criterion, so they are, they've got disseminated malignancy, or they're very short of breath, or some of those things. So objectively, they're suffering. How much suffering is it? I can't tell. I have to accept that as long as it's broadly plausible, I have to accept what they're telling me.
Okay, thank you. Well, let's go to this question of capacity. And in terms of questions received prior to this evening's webinar, a very considerable number went to the question of capacity, and particularly whether a person, are there any circumstances where a person can declare their wishes in advance when they have a condition where capacity will be lost. But first of all, just explain what the term capacity means, please.
So as a shorthand and in lay terms, I usually say of sound mind, because most people understand it. What it means is that the person has the ability to receive information, process it, and give a reasonable answer. It doesn't have to be an answer that I agree with. And if I can give you an example from outside the VAD domain, Jehovah's Witnesses are proscribed from accepting blood transfusions. So there are a number of legal cases where Jehovah's Witnesses who are bleeding to death have said, no, I don't want to receive blood products. And as a result, they've bled to death. That's not a decision that I would make. So it's not about what Patrick Bolton thinks is reasonable, but there is a receipt of the information, a processing of the information, a decision-making process, and an answer that fits within their worldview and is plausible. And the other thing to take away from that, I hope, is that capacity is situation specific. So somewhat tritely, I often say you might be able to make a decision about whether you want VAD or go home, where you can't make a decision to sell your BHP shares, because your BHP shares maybe, perhaps I'm being unfair, but selling your BHP shares is a much more kind of complex decision to take in many more variables.
Yes, I understand what you're saying there. And again, if you have more questions about capacity, please ask them. We're getting a number of questions, so I want to go through some more key elements, and we'll do it. I don't mean to hurry you, but let's just do it efficiently, because we can return to topics. So another key criteria, and I should say all these eligibility criteria all apply. It's like this list has to be met. And the next one is it must be voluntary, the person's own choice, and they're not acting under pressure or duress. How do you go about assessing that?
So for me, that requirement of the Act brings three bits. One is I make an assessment of the situation as I'm assessing somebody. You know, if somebody's standing over them, prompting them, and sometimes where communication is an issue, either because of English language, or people with motor neuron disease often have to write on boards or use communication devices. And so there may be an intermediary, and somebody might say, look, I understand mum a lot better than most people. Let me tell you what she thinks. You know, then you've got to be really careful about what might be slipping in. But so as you look at the total situation, you ask the person, and if necessary, you ask the person on their own in a safe way. And the other thing that hooks on as a thought for me is that I'm obliged to tell people that they must not be acting under coercion or duress in making their VAD decision. So when I think about that point, I'm always careful to say to people, you need to know that this is the case. And that, I guess, provides a further prompt for them to flag concerns if they have them.
Another eligibility criterion is enduring request, continuous, ongoing, and a lasting period of requesting. Why is that significant? And then I'd like to hear about the first request and how that needs to be done.
So, because with VAD, you can't change your mind. You know, once you get it, I'm not saying what happens after you get it. That depends on your belief system, but there's no going backwards. And so sometimes we have people. It might be 5%. I'm somewhat making it up, but of people who actually don't have a consistent view. There's a series of visits, and you'll cover that. And clearly, in the first visit, they say this is what I want, because otherwise they don't progress. But you come to the second or third visit, and they're going, "Oh, I'm not really sure." And then they need to convince you that they're not having second thoughts. And on some occasions, we have said to people, look, I can't continue with this process. I'm going to have to discontinue this process. And if you want VAD, we're going to have to recommence it.
Okay. So that's, and I won't go into detail now into the first request, but if you Google voluntary assisted dying New South Wales, there's a description of what's required. It needs to be in writing and to meet certain processes. And I think, you know, there are 11 steps in voluntary assisted dying, according to the information on New South Wales Health. We're not going to go into every little detail, but is it fair to say that the issue of multiple requests over time and more than one assessment of capacity is built into the system?
That's right. So every stage when a doctor deals with somebody requesting VAD, we have to be confident that they want it and that they have capacity to say that.
Fantastic. And look, the dying process, there's two options. There's self-administration, the person giving the medication themselves, or there's doctor or nurse provision. Again, how does the patient go about making that sort of choice? It's
largely patient choice. The oral substance is a drink, 100 mils. It's a bitter drink. You take it yourself, and because you take it yourself, you can do that independently of your VAD practitioner at a time of your choosing, and so it has that benefit. The substance, we encourage people to drink the substance quickly because half of people are asleep in 5 minutes, half are dead in half an hour, and 98% are dead in 2 hours. That does mean that a few, there have been deaths that have taken up to 12 or 16 hours, a couple of those. I was worried about that. There have been 3 such deaths in New South Wales since VAD started. And in fact, in 2 of those occasions, the family said, actually, it was great. We spent more time farewelling the person. So it's got those, that's a brief sketch of the sort of the pros and cons of that process. The alternative is practitioner administered. We can do that at home or in hospital, so it doesn't determine location. And that's a series of injections, and the person is, the time between the first injection and death is about 10 or 15 minutes. Sometimes we would discourage people from having oral administration. If they've got a bowel obstruction or if they've got motor neuron disease and they don't swallow well, then it's an unsuitable thing for them. And we would worry that though that disability meant that the drug wasn't going to be effective and therefore they couldn't use it.
I'm going to just put aside for a moment the issue of family support, particularly if someone is choosing to do it themselves at home, because I want to get the 2 more key elements out and have some questions and then bring Professor Chye to our conversation. But what we do need to say is it is open to a hospital and to a medical practitioner to not provide the service, I guess, conscientious objector. And what if the doctor, we'll talk about the individual doctor first, if the individual doctor is a conscientious objector and a patient does ask them about voluntary assisted dying, what does the Act say they must do?
I just want to step out because there's some ambiguity about that. I'm always very careful. VAD is about death. It's an emotive subject. When I'm talking to peers, colleagues about VAD, I'm careful to say, I'd like to have a VAD conversation with you. Are you okay with that? Because some of them are not, and I don't want to put them to distress them. The Act says of practitioners who want to be conscientious objectors only that they need to say to the patient, I'm sorry, I can't help you, and to make an annotation in their medical record and in a thing called the VAD portal. This last is, as I understand it, only for statistical purposes, so it doesn't result in any on referral. As a result, in that circumstance, the person requesting VAD is left high and dry. The ambiguity arises because there are some people who are saying that's fine for the Act, but common duty of care means that the doctor ought to on refer them to somebody who can help them. That's, as a legal question, that's unresolved, and I guess as a moral question, that's up to individuals.
Oh, okay. I mistakenly thought that the Act did not require the doctor to refer, but you're saying there's still some ambiguity there.
So the Act doesn't require the doctor to refer, but there are quite authoritative people who are seeking to make the argument that the doctor is under a duty of care obligation to refer. I'm remaining agnostic on that.
Okay, thank you. And look, just finally, nursing homes, group homes, certain residential services are not permitted to refuse access to voluntary assisted dying. Just explain that a little more, please.
So as you said, hospitals which are defined legally can choose to be non-participant organisations. The ones that I'm aware of are faith-based organisations. But nursing homes, even if they're faith-based, cannot choose to be non-participating. They've got to support VAD. I conjecture that that's because the intent of the Act is to allow people to receive VAD in their home. And if you're living in a nursing home, that's your home. And bearing in mind that, as you've indicated, the VAD process is a moderately lengthy one, and it may be onerous for somebody who's in a nursing home and therefore impliedly likely to be disabled to make a whole bunch of trips to somewhere else just to be assessed for that.
Look, thank you. If you've just joined us, because I see some numbers have increased, Associate Professor Patrick Bolton, who's the medical lead for voluntary assisted dying in Southeast Sydney Local Health District, has just been outlining the key elements. We have a number of questions. So what I'd like to do is to take 2 or 3 questions, and we'll come back and do more questions later. And then I'd like to invite Professor Richard Chye to talk about the palliative care services at Wolper and what happens if someone there or at another palliative care service that does not offer VAD, what happens to that individual patient. So welcome to Dr. Lena Safro, our question moderator. Can you give us one of the audience questions, please? Your microphone is off again, I'm sorry. Thanks, Lena.
Thank you. There are quite a few questions, and one of them is someone wants to know if all states and territories are in the same line with the voluntary assisted dying protocols.
Okay, what's the answer to that, Patrick?
The short but slightly clumsy answer is largely. The territories are not. The ACT is contemplating it. I believe that the Northern Territory doesn't have anything since the Philip Nitschke stuff 20 years ago. The subtlety is, my understanding, and this is an impression rather than a precise answer, is that the legislation in Queensland and New South Wales and Western Australia is quite closely aligned and therefore quite similar. But in Victoria, the legislation has been in force for slightly longer. It's been there for about 4 years, and it's more restrictive. So, for instance, in New South Wales, a doctor is able to raise the possibility of VAD with a patient, so long as the doctor does that in the context of all the therapeutic options. You know, you can have another course of chemo, you could have palliative care, and/or you could have VAD, and/or you could do nothing. In Victoria, the doctor has to wait for the patient to come to them and say, I've heard about this thing called VAD and I want it. So unless the patient has to be really active. And then the other big difference is that certainly those 3 states I've mentioned, New South Wales, Queensland and Victoria and Western Australia, the state health departments support VAD. And so it's like much other healthcare in Australia, it's free at the point of delivery. In Victoria, it is not subsidised by either the Commonwealth or the state. So if you want VAD, either the VAD practitioner has to provide it to you pro bono or you're out of pocket for some quantum.
Look, thank you. Can I just suggest, Patrick, just for the purposes partly of time, that we just confine our conversation tonight to the New South Wales legislation for which you're responsible. But in a nutshell, if you're watching this in any other state or territory in Australia or anywhere in the world, you need to inquire what your local legal situation is. Another question, please, Lena.
So there are quite a few questions regarding what would constitute intolerable suffering. Does it include mental illness or suicidal ideation?
No, you can't, in any Australian jurisdiction, get VAD for mental illness. It's been introduced into Canada in the last couple of years after medically assisted dying has been a general option there for 25 years. So for me, that's somewhat about the maturity of the community debate and so on. And indeed, one of the things that we need to be careful of in the context of assessing capacity is that the person isn't depressed. So it's not, you know, if you're dying of some illness, it's not unusual for you to be feeling pretty bad about that and not really happy with the world. That needs to be distinguished from the clinical mental health disorder of depression, in which your thoughts are distorted by the illness, because if that's the case, we can't offer it.
And really, you did speak earlier about the assessing of, it's very much under the legislation, the person's perception that their situation is intolerable, that their suffering is intolerable. And I had the sense, listening to you, Patrick, that you give considerable weight to that individual's perception. And I guess some clinicians may do that to varying degrees, just because your individual clinician's making
100%. You know, I guess this is a bit of a cheap out, but these are people who are choosing to die. So the alternative is, as long as they understand the alternative, they're thinking that either now or in the near future, death may be a better alternative. So that, to some extent, is a kind of a thing on the, scales of balancing their suffering.
I'm going to take one more question now. I know there's more than that, but I want to come to Professor Chye, and then I'll come back to open questions again. But one more, Lena, please.
Well, this is the question that comes up several times along the lines of, I don't want to live with dementia. I'd like to have an opportunity to end my life. Why can't I make that decision for myself?
I can't answer that except to say that at present in New South Wales, you can't put a choice for voluntary assisted dying into an advanced care directive. And so I'll only go into it if it's appropriate, but this is why it's so important to have an advanced care directive, even if you've got access to VAD, because if you lose capacity, you stop having access to VAD. And then I assume that you wouldn't want active treatment if something terrible happened to you.
And just to be clear, as you explained earlier, the Act requires the individual seeking voluntary assisted dying to have capacity at the time.
Correct.
It's something you can declare in advance. Many people requested that about all sorts of conditions, but the law in New South Wales right now says, no, you must have capacity at the time.
Exactly. That's the issue.
Look, thank you. And thank you so much, Patrick. And what I'd like to do now is to reintroduce Professor Richard Chye, a palliative care physician with over 28 years experience, a director of the Sacred Heart Supportive and Palliative Care Service at St. Vincent's Hospital, and also palliative care physician at Wolper Hospital. And welcome to you, Patrick. Look, I wanted to give people an overview of the service of palliative care at Wolper. But first of all, there are some responses to what has come before. And when we spoke before tonight, I said, what are the three key messages you'd really like people to remember? So could I just go to those first, and you may wish to add something as well. But your first message was, it's normal. It's a normal emotion to want or to think about voluntary assisted dying when facing a life-threatening illness. Can you tell us what, in your experience over the years, are the sort of common fears that people have that might lead them to think about getting assistance to die?
Good evening, Julie. Yes, that's the first thing to clarify is that I'm no longer director of the service. I'm actually a senior staff specialist now. And yes, I have been director of the service for more than 25 years. And I thought that it was time for new leadership, young leadership with someone with ideas take over the service. But thank you, Julie. Yes, I think that it's normal. And as you said just in your poll, people would want VAD if they wanted it for themselves. And I guess the question is why? Why would they want it for themselves? And a lot of it is fear. Fear that they're going to be in pain as they pass away. And no one wants to be in pain. Fear that they're going to be undignified. Nobody wants to be incontinent of urine and feces and lie in bed all the time. No one wants to be able to not recognize family and enjoy family. So all of those are very common reasons as to why people want VAD. And it's a very normal emotion to have, because all of us have seen a loved one pass away. And very often, and I'm sure Patrick Bolton would say that our hospitals don't look after our dying very well. Our nursing homes don't look after patients who are dying well at all, mainly because they don't have the resources, they don't have the training, they don't know the know-how of how to look after someone who's dying. I'm not going to say that palliative care is going to look after 100% of everyone who's going to die peacefully. No, it's palliative care will not be able to do that, and I will never promise that I'll do that. But we as palliative care specialists will always say we'll do the best we can to minimize discomfort. And I think importantly to try and minimize distress from a lot of the symptoms, a lot of the attitudes, a lot of the undignified scenarios that patients have. And our role is also not only to reduce the distress of patients, but also to try and reduce the distress of loved ones around them. Because VAD was put onto the agenda because some politicians were distressed to see their loved ones pass away, and see that their loved ones were in very undignified. And that goes back even to the HIV pandemic, when lots of young people died terribly with AIDS. And AIDS was a very difficult disease to look after. And as you would recognize, it was a wasting disease in addition to all the different infections. And it was also, in a way, a burden for a lot of those patients to want lots and lots and lots and lots and lots and lots of treatment that caused lots of side effects, but they all still wanted the treatments because they wanted to live. And when they came to a time when the body was ravaged by the disease, by infection, by the side effects of treatment, then they didn't want it for themselves. The patients didn't want the treatment anymore. But it was also the effect of seeing that in their loved ones, that lots of family members, remembering these were all young patients who passed away with AIDS, that all their partners, all their friends were also very young, who have now reached the age of in their 50s, 60s, and still have that notion that dying is very terrible. So it's a very normal emotion to have. And I think we need to I recognize that it is hard to live with a diagnosis of cancer, and to worry about what cancer is going to do to me as a person, what cancer is going to do to my loved ones from having to look after me. What is my body going to have to deal with all the treatments from a cancer perspective? But it's not only cancer, it's also all the treatments from heart failure, from kidney failure, from respiratory failure, all those diagnoses that Patrick Bolton talked about. Because I can tell you, some heart failures have a worse prognosis than metastatic breast cancer, even though it's not always recognized. But it's again, all the treatments that patients who want to live and are willing to take medications, which then lead to lots of side effects, and in the end, they don't want to live as they see themselves. So the first thing is, yes, it's a normal emotion. We want to make sure that I acknowledge that, and then that's a starting point to go forward.
What I'd like to do, if I may, is to just run through, give people an overview of the palliative care service at Wolper Hospital, and then also to hear what you've done either at Wolper or at Sacred Heart, where you work, if someone actually asks for voluntary assisted dying. But let's just go to this question of dignity. And when I asked you, what is the purpose of Wolper's palliative care service, you said it's to uphold the dignity of the person, and then you stopped. I was kind of expecting more, but you said to uphold the dignity of the person, and that in your experience, as you've indicated, the main reason people will ask for voluntary assisted dying is not in fact pain, which we often would imagine it is, but rather those other things you've mentioned: bedbound, incontinence, loss of independence, but also the fear of being a burden on others. But let's come to what you do. Just give us an overview of what do you do to maintain the dignity of a dying person in your palliative care service at Wolper and Sacred Heart. The practice.
Wolper provides palliative care, and it provides palliative care as part of a wider palliative care service across eastern suburbs of Sydney, but even wider than that as well. Wolper works with teams from Sacred Heart, from St. Vincent's Hospital, and they also take patients who normally live or have family members who live in the eastern suburbs, may have had their treatment, say, at Lifehouse or Royal North Shore Hospital elsewhere as well. So Wolper Hospital provides palliative care as part of a wider provision of palliative care in our public hospitals, our other private hospitals, and our community as well. I see palliative care doing 4 things. One is helping symptoms. Obviously trying to minimize pain, minimize nausea, vomiting, constipation, to try and make sure that patients live with as little symptoms as possible. And even then, and even when patients are still having cancer treatment, even when they're having a chemotherapy or radiotherapy, we provide that to heart failure patients who are still having their diuretics. We still provide it to your lung failure patients who are still having oxygen. That is part of palliative care in terms of their general care of looking after these patients. The second part is just providing that physical care. We talked about providing care for people who are bedbound, who are not able to get to the bathroom. A lot of patients fear being incontinent in bed because they burden families, yes. They burden nurses, yes, because they fear that they have to have someone clean up after them. But I can tell you a lot of nurses see palliative care as a huge privilege to be able to care for lots of patients when they're incontinent, to wash them, to bathe them, to clean them, to feed them. A lot of nurses in palliative care, Wolper, see that as a privilege. Privilege to be able to be part of that patient's life, to be part of that patient's care. And I tell patients, yes, you may feel undignified because you're incontinent, but and you fear that you have to put a lot of burden on nurses, but the nurses at Wolper take it on without question. They are there and they want to be there to look after everyone, no matter how undignified they may be. And I can tell you a lot of nurses at Wolper see a lot. The third part is to try and reduce and help patients understand their disease. What does pain mean? What does nausea mean? What does weakness mean? Because being able to educate, being able to help patients understand what's going on with their bodies can reduce a lot of the stress. I talk a lot about what does dying look like, and it can be very peaceful. When I explain that to lots of patients, there's a sense of relief. So in other words, I take away a lot of the fear by having frank conversations about what to expect. Part of this reducing distress among patients is also to reduce distress among their families as well, because it is very frightening for families to see someone who is dying, because very often we don't see dying. We hide dying and don't see how a loved one dies. Yes, there will be few, obviously, who have reached the age, as many of your audience, who have seen patients who pass away, but many actually have not. And they fear dying. They fear that patients are going to be dying in pain. They fear that they're going to be in pain right up to the end, rather than having that patients are sleeping most of the time as they pass away towards the end. So trying to explaining to patients, explaining to family what to expect is important, because that reduces a lot of distress that a patient may have, a family may have, a friend will have. The last part is, whilst, yes, we talk about the ravages of disease, the ravages of treatment, palliative care also includes lots of access to physiotherapists, occupational therapists, dietitians, speech pathologists, to try and maintain or optimize function as much as possible. In other words, to live with their disease as well as we can. Yes, I know a lot of patients are not going to be able to run the marathon, and I don't expect to, but we can make patients live much more functionally and to be as independent as possible for as long as possible. Yes, reducing the stress is important. And part of reducing that distress, as I mentioned, is trying to make goalposts much more realistic for our patients and for our families as well. So that's what I mean by dignified, by addressing all those issues, not just physical pain, but all the other existential issues that everybody goes through, and everybody go through all those questions, all those distress.
Now, I want to come to that existential issue and the role of faith and religious values in a moment, and I will invite Rabbi Gad Krebs to join us at that point, but just as concisely as you can, and I think you've got an example from Sacred Heart, what do you do if a patient asks for voluntary assisted dying and you're working at the Sacred Heart service or at Wolper, which does not provide voluntary assisted dying? What happens?
If a patient asks for VAD, we firstly acknowledge that they've requested VAD. But very often, a lot of our patients ask for information. What is VAD? I've heard about VAD, and what does that mean? And also at the same time, we clarify with every patient, what does that request for VAD actually mean? In our for many years, 20 or 30 years, 5%, one out of every 20 patients, ask questions about dying and wanting to die early. The requests has already started way before legislation came through, because they want to know, what does dying look like? They want to know, can their death be hastened? But we go through and go behind that question. We want to understand, is it very often pain that has led to their request? Is it being undignified that has led to the request? Is there fear that has led to the request? And very often, yes. And what palliative care can do, and most of the time, is to relieve a lot of that fear, relieve a lot of those symptoms, and those requests to die go away. Mostly. I wouldn't say all, but mostly. But if a patient asks, then we obviously clarify what they want, why they want, and if there's anything that the request for VAD has hidden the underlying question. So we need to tease that out. Very often it's about, what is VAD? What does that do? What does that mean? And yes, if I'm asked, even though I don't believe in VAD, and Wolper and the Catholic faith-based hospitals don't, I explore what they want and explain to them what the process actually means. And if they want more information, then I tell them to go to the New South Wales Health website, or, as you said, Google New South Wales Health VAD, and then they can get the information themselves. And we encourage them to get information themselves.
And just a reminder for those who joined us earlier, there is a statewide number, and it takes you to a navigator service where there are people whose job it is to give you information, to refer you to identify VAD providers that you could access, and other resources. Just very quickly, if you have had a case, I know what I wanted to say. Is it the case that at Wolper, if a navigator member of that service wishes to come to Wolper, that is fine. They can come to Wolper and talk to the patient, but any assessments and the other processes associated would happen elsewhere. And that you have had a patient through Sacred Heart who did move between Sacred Heart and a hospital while they were deciding whether to proceed or not. Is that it in a nutshell?
Yes, it is. We've also had a patient at Wolper who was able to get home to be assessed on 2 different occasions, and to get home for a 3rd time to be almost given the medications for VAD, but the pharmacist at the time felt that the patient did not have the capacity anymore at that stage, and actually did not dispense the medications for that patient. And the patient came back to Wolper and passed away peacefully with all his family, friends around him. So yes, if patients are able, we allow them to go out of Wolper for the assessments. We at Sacred Heart, we even transferred a patient to Prince of Wales Hospital, where they got their 1st and 2nd assessments, and that patient's now come back to Prince of Wales to wait for when he was ready, or when his family was ready. So in other words, whilst Wolper faith-based organizations do not support VAD, do not support the process of VAD on their premises, we all recognize that patients want VAD, but we will not stand in the way of VAD. We'll provide information and give them the necessary means to obtain information and obtain assessments. Yes, we have not reached the stage where a patient who still wants VAD, but is not able to get to, say, Prince of Wales Hospital or get home to be assessed. We have not reached that situation at this point in time, because very often patients who are not able to leave the hospital to go home or go elsewhere because they're already too sick, it already means that for them dying is very soon. And whilst Patrick and his colleagues will try and expedite VAD as quickly as possible, very often these patients pass away before anything is done.
Look, thank you, Professor Chye. What I'd like to do is to invite onto the screen to join our conversation our special audience member who's been listening from the start, Rabbi Gad Krebs, who's the college rabbi at Moriah College. Welcome to you, Rabbi Gad. And what I want to do is discuss the impact of faith and religious Jewish values on decision-making. If you could please leave Professor Richard Chye with us, thank you. I wanted this to be a 3-way conversation. And then I want to let our audience know that I will be then returning for the rest of the time to try and answer the questions that remain. I'll be coming back to Dr. Lena Safro. But one of the early questions that came in was, what part do different religions and cultures play in decision making? And I thought, just before I ask you, Richard, how you manage it, Rabbi Gad, can you give us a sense of the sort of key Jewish principles that are guiding the sort of sensitive decision making that you've been hearing about around death? Welcome.
Okay, great. Thank you, Julie. And I think it's indicative of the fact that 90% of the respondents to the earlier poll said that whatever I have to say will have absolutely no bearing on their decision making whatsoever. So, and I think that is quite indicative of the Jewish community as a whole. I'm not sure what the percentage of members of this particular core are Jewish, but the Jewish community is one that, on the one hand, holds so much of their culture and faith very close to their hearts. But often when it comes to these sorts of life questions, the decisions that they're making are not necessarily in consultation with rabbinic guidance. That being said, I will try to give as an authentic an approach to the question of end of life as possible. Life is has absolute sanctity, and there's a mitzvah, there's a commandment to preserve life and to do whatever we can to ensure safety and longevity within life, and we put enormous amount of effort to that. That being said, there's no mitzvah to suffer. There's no commandment that one should endure suffering purely for the purpose of living a few days, months, or longer under terrible pain. And the idea of suffering has value within the Jewish faith, meaning that we do not see that suffering, that a person should just, toughen up and swallow their pain as somehow this is God's wish for them, and they should just endure whatever they can to eke out another second or whatever in life. That being said, you know, that where the nuance comes in is how do we distinguish between prolonging life as opposed to prolonging death? And that is really where the point is going to come. And a large part of end of life questions really comes down to intent. Very often within the palliative world, life is shortened through palliation, but the intent is the alleviation of suffering, not the shortening of life. And therefore, there's the vast majority of rabbinic authorities are very comfortable with palliative care because that is the intent. We're not trying to shorten a person's life, even though we know that's exactly what's going to happen. On the flip side, the idea that we will deliberately cut a person's life short is very problematic. And so VAD and all other forms, manifestations of shortening one's life intentionally is very theologically problematic, and we steer clear from it at all costs. That being said, like most questions, and I imagine both the distinguished professors online would agree, is that to try to give blanket one size fits all decisions for any life situation without being able to appreciate the nuance and the complexities of everybody's individual case, the Jewish legal system is no different. And therefore, when navigating end-of-life questions, it is critical to have somebody to be able to guide you, to be able to understand a person's specific situation, and to do whatever one can to be able to support them during their end-of-life journey in a way that is both as pain-free as possible, but as dignified as possible, without unnecessary suffering, but appreciating the value of life. So I suppose there are a whole bunch of balls there that you're trying to juggle at the same time. But my sense is that that gray zone is where we need to find a certain level of comfortability in the discomfort.
Oh, thank you, Gad. And could I come to you, Professor Chye, because one of the conversations we had before tonight was this issue of pain. Now, you've said earlier you don't think pain is the primary reason a lot of people want a voluntary assisted dying or maybe thinking about it, but it can be to do with the fear of loss of dignity. We've talked about that before. But I did say to you, you know, is there pain that you can't manage? Because as someone who's had cancer, I had amazing pain, managed very well. But I wanted to know, is there pain you can't manage? And you said, yes, that can occur. But you said, but we can make patients unaware of pain. And I think that goes to what Gad is seeking to it's sort of a clinical way of going to what Gad is referring to. Can you explain what you mean that for that minority of people for whom you have difficulty managing pain, what does making them unaware of pain mean?
So as Rabbi Gad correctly said, there are some situations where pain is very difficult to get on top of. And that pain as a result becomes very distressing. Yes, it may be physical pain that has caused the distress, or it may be existential pain that patients have that causes distress, causes a lot of angst.
What does that mean to you, that word existential pain?
Existential, I'm sure Rabbi Gad probably has a better definition for or understanding or explanation of existential, but basically it's what people have mentioned in the chat. It's about their suffering. It's their global suffering, and that suffering distresses that patient, and that suffering is something that they can't reconcile within themselves. And they become very distressed, very anxious, very angry, whole lot of emotions that they hold, sometimes burst out, but very often hold on the inside. But it comes out not necessarily as saying, I am in existential distress, but it comes out as being very anxious, difficulty sleeping, lashing out. But it's all about fear. So yes, there are some times when if that distress from pain, distress from existential things are not able to be got on top of despite pain medicines, besides antidepressants, anxiolytics, despite lots of talking, and that continues to distress the patient, then yes, sometimes I would make the patient unaware, meaning put them asleep, and make them asleep as much as possible. But it's very hard to keep someone asleep 24 hours a day. But to make them asleep most of the time so that they're unaware of their distress, they're unaware of their pain. And when I obviously make them unaware, then they can't do anything. They can't feed themselves, they can't drink. And as time goes on, the body withers away and dies. So that's when I say that I make them unaware. Very often, however, when patients are in the dying process, meaning that they have only 1, 2, or 3 days left of life anyway, yes, and when they are not able to think clearly, they get very confused or agitated, then yes, I would also sedate these patients to make them less aware, but also to make them calm and much more peaceful in their last 2 or 3 days of life. So that's what making them less aware of what's going on actually means.
Thank you. And Gad, I know these are very complex, but the question, the way Professor Chye is describing it, the intent is not to end life, it's to reduce suffering. And is that the interface between faith and clinical judgment?
I think it's a very hard call to make. You know, as we discussed a little bit earlier, when a person says they're suffering, at which point do we, you know, physical pain, albeit I'm not sure the metrics and how one determines the level of a person's physical pain other than self-reporting, but on mental anguish, is you know, at which point do we consider this a legitimate form of suffering that is warranting to making them unconscious, or and as opposed to, you know, I look at many people, many a hospital bed that I've sat beside, you know, towards the people's lives, where especially matriarchs and patriarchs of the family that are really struggling with the idea that instead of being the figures that were doting on the family, they are now the ones that are being doted upon, and the real existential struggle with that. Now, there are ways of navigating that, and so I would hate to think that, listen, we know this is distressing you, and the idea that, you know, that the end is not, like, I don't know how we would measure that, but I would be very reticent to suggest, and I don't know if this is what you're suggesting, Dr. Chye, maybe Professor Chye, maybe I'm misunderstanding, but like, when the pain is existential as opposed to real physical suffering, I don't know if I could see that would be a legitimate reason to knock someone unconscious, so they shouldn't have to deal with the real struggle. We all struggle existentially, and life is one. I mean, there's a whole form of philosophy and psychology on existential, where people real suffer, and people who choose often to end their life earlier is not due to physical pain, but due to existential struggles, whether it be mental illness or whether it just be existential pain. So, like, I find it very difficult for that to be a rationale. Even if a person would admit it and say, listen, I'm struggling, I'm scared, I'm worried. These are natural, normal feelings for people to be having, that I'm not sure we can numb them. And I don't know if we do them a disservice by numbing them. So if I've misunderstood, please correct me.
No,
that would be my position.
This doesn't become more profound, and gentlemen, I'm under pressure. I do want to get to some questions, but I must give you a right, Richard, if you could give, if possible, a short response to that, to what is obviously a profound issue.
I think, yes, it's a clinical judgment as to what is distress. And from my point of view, I recognize the stress. I recognize that patients are suffering. I don't take the view that I know best. And as Patrick says, that I don't know and I can't feel a patient's distress, a patient's struggle. I can't, nor will I. I won't take the idea, I won't take the ideal that I'm paternalistic and I know best. No, it has to be a joint decision between myself and the patient. And that's what we teach our medical students, that we jointly do that. I might just say, yes, I'm the doctor that knows what medicine can do and what medicine can't do. And our patients don't have that training. So my role is not to say, this is what you must have. My role is, this is A, B, and C. And because of my training, my experience, I would say, I would recommend A, rather than tell the patient, you must have A. I would never do that. I make sure that the patient is part of that, decision-making, but also recognize, yes, I have the experience, I have the teaching to know what I think is best. Yes, the patient may disregard my recommendation, but at least they have my recommendation, and then they can go forward. Whatever the patient decides, I will still support that patient with whether they want A, B, or C.
I'm going to have to close what I've personally found a very profound and fascinating conversation. I want to invite Associate Professor Patrick Bolton back onto the screen, and let's see if we can do, we've only got 10 minutes left, but let's see if we can do 2 or 3 questions a little concisely. Dr. Safra, if you could join us on screen as well. Could we have a question, please, from the audience?
Sure, Julie. So there is a very good question regarding the experiences of the families of the people that have completed VAD. Is there a way for them to track the experiences, and is there a way for these families to contribute their experiences?
Thank you very much. Patrick Bolton.
That's a great question, and one that's difficult to answer, not just in VAD, but in healthcare. How do you actually get authentic experiences from people who've been on a healthcare journey? And I guess often it's reduced to a number, and I don't think that's a very good way of doing that. What I respond to more is patient stories. They're expensive to collect because of the time and so on. We are starting to collect some patient stories from people on our VAD journeys, and I should say more generally in other aspects of healthcare provided by our hospitals. And this is a bit artificial, I guess, but there are a couple of videos which are patient stories but have been prepared for, there's got to be a better word that I can't think of, it, marketing purposes. You know, they're authentic stories, but they're there, and they were done by actors from scripts provided by family members talking about their experience.
If I could just say, this is me jumping out as a facilitator and commenting, I think the health system in New South Wales and elsewhere has a lot of work to do to bring the family voice in a more sophisticated and genuine manner forward. And I think that's the thrust of that question. There are things called patient-reported outcome measures that they're trying to bring in New South Wales and elsewhere. But I think that particularly in this area, the role of the views of the family would be most welcome. Richard, did you want to comment on that just quickly?
I think that yes, we all have experiences. Prompts at the moment being used by New South Wales Health are good for someone who's had an appendix removed, who've had a gallbladder removed. But those prompts at the moment don't ask questions about how was the dying process. That's a very different questionnaire that we are working to find out how to ask those questions and when to ask those questions, because when patients have passed away and you ask families, some of it can be still very, very raw. So you've got to be very careful in terms of, yes, we want feedback, but we also want feedback in appropriate time when there's less, obviously, emotion and rawness around. And that's the hard part of it in terms of end-of-life care and how end-of-life is being managed in our hospitals.
It's really an area for the world of psychology at universities to do proper research. But let's take another question, please, Lena.
Sure. So someone in the chat mentions the grief line support groups for family members of the people who have completed VAD, and they want some explanation.
Patrick, are you aware of that service?
Yes, but not in any great detail. The service model that we in Southeastern have, and I should say the service models differ from different local health districts, is that as well as having doctors, we have navigators. And the intent of the navigators is to be the mortar between the bricks, the joining up the VAD journey. And our intent, which is at least partly successful, is that they form good relationships with the families. And they always do some follow-up that's guided by what the family wants. And look, it's subjective, but we are attuned to family dynamics, and some family dynamics suggest that there might be more work to be done there than others. And where that exists, we will try and it's horse to water stuff, but we'll try and get the family to get the support they need. The grief line might be appropriate, GPs might be appropriate. Sometimes individual counselling, often arranged by the GP, is appropriate.
Could I ask Gad to rejoin us on screen? And just while he's coming, I'd come to you, Professor Chye. When I was a cancer patient, psycho-oncology, it was called, psychological services were offered to me, but they were also offered to my partner and my adult children. So that was built into the cancer care system. Are you able to offer us any insight as to whether that could extend beyond the cancer world?
Absolutely. Within palliative care services, is not just a doctor, nurse. Remember that there are lots of things that we try and deal with from a palliative care. It's not only just the symptoms, it's the care, it's the psychosocial support, and also the physical support. So part of it is, yes, we talked about physiotherapy, occupational therapy, dietitian, speech pathologist to help the physical side of things. But we also have social workers, psychologists, psychiatrists, counselors. And yes, Wolper has access to all of them for patients and families to help come to terms with what's happening. And we feel that palliative care is not about just looking after patients as they are dying, because I always say that families need to be strong. They need to be rested because they are part of that patient's care. If someone is very tired because they've not got much sleep, or they're distressed because they don't know what's going on, then it's very hard for them to be part of their loved one's care. And we certainly want to support loved ones to be part of the care system. So in other words, we don't only look after patients, we look after the people around the patient. And that's where Wolper does have, as I said, psychologists, social workers, psychiatrists, who are all there to be able to provide as best as we can. Yes, there is a lot of ask, and like any other palliative care service or any other hospitals, those are limited to some extent, but Wolper will try and do the best they can.
And Gad, Professor Rabbi Gad, why I wanted you to come back is that some people watching tonight will be in faith communities of whatever faith, and will have a relationship with their rabbi. But most of us, or many of us, come in contact with ministers, rabbis, and priests at this time of life. So I guess I'm interested in your thoughts on the support for the family and friends.
So I can only give you a Jewish perspective. I can't go beyond that. Perhaps where the religious worker differs from the other professionals is in most cases, or many cases, we have a long-term relationship with the family and the broader family, not only the patient, but the family as a whole. We will hopefully navigate the difficulty and walk the journey with them. But once the person passes on, our role continues. And so living with the decisions that have been made for the family that's going to continue well beyond the passing of the individual is helping to navigate the whole process. And that's where we are involved here. We don't check out. Once the patient passes on, the role of the physicians pretty much ends at that point. Now, it could be that the social workers can offer some level of support, but once people are no longer in the system, they're no longer the problem of the system. Whereas from a Jewish point of view, the rabbinic relationship between the family and the rabbi is one that started way before, more continuous. So it's not only, it doesn't end not at the passing, doesn't end at the funeral, it continues well beyond there. So helping and supporting the family through the entire decision and being able to be, to a certain degree, holistic with the whole family, how this period in their lives are going to touch everybody and how to navigate them through it. So that's where where we I say that in my time in the rabbinate is the most rewarding. It's where you are being able to hold people at the most vulnerable. Where I agree completely with the doctors is my role is not to tell people what to do. So just as you would provide them with what the options are out there, I similarly would say, this is what the Torah suggests. These are the options. These are and then the decision that is made, ultimately, we will support them and love them regardless. And even if they do make a decision that is counter to the Torah's perspective, we don't turn our back on them. We will continue with them. So if they were to choose VAD, and that is, not according to the directives of the Torah, that doesn't mean that, okay, well, you've turned your back on us, goodbye. We would very much walk with them. And I've had situations, not as VAD, but in other situations where people end of life decisions have been made, where people have made the decisions which are not consistent with Jewish values, but nevertheless, it's like, okay, let's carry on. The relationship continues.
And our time is up, but I just want to say I've had the opportunity to go to synagogues different times, and there does seem to be a lot of remembering of the dead on the date of their passing. And there's a very respectful and structured approach to memory. Is that an accurate observation?
So that the term of zachor, remember, is we're a little bit obsessive with it in Judaism, not only with individuals but with events. Our whole system, from Sabbath every week to every festival, has some element of Zeicher involved with it. So not only remembering those that have passed, but the whole concept of remembrance is very much at the core of Jewish faith and traditions.
Well, look, we've come to the end of our time, and I just really want to apologize for not getting to more questions. These are such profound questions, it's hard to do quickly, but I hope there's a great deal there that you will find useful. I want to thank Associate Professor Patrick Bolton, Professor Richard Chye, Rabbi Gad Krebs, Dr. Lena Safro. This is deaf sign clapping. Do you mind all just smiling and giving each other a warm clap? Because really, you've done a marvelous job. Yes, it looks a bit funny, but it really is deaf sign clapping. I just want to remind you that this webinar has been recorded and it will be available on the Wolper Jewish Hospital website. Remember, if you want to know more about this and to get the statewide number and so on, if you just Google New South Wales VAD, VAD, you will get loads of information, or New South Wales Voluntary Assisted Dying. I must say to you, this is the last webinar